The title of my presentation is Antiretroviral Treatment for Pregnant and Breastfeeding Women. What is the current status of implementation? But given that we've been talking a lot about elimination, the other title that I could have used is, are we there yet? The answer to that question kind of depends on who you talk to. So if you're talking to the policymakers, this slide, I have to thank WHO for pulling this slide together, and it shows the current status as of July 2018 of the adoption and rollout of option B+. And what it shows you is that 100% of countries that responded to the survey that WHO sent out, it's about 160 countries surveyed, said yes, we have adopted option B+, and virtually all of those countries, apart from the ones in light green and lighter green, are implementing the policy at national level. So that's obviously very impressive, and you might think, well, mission accomplished, but actually, is it working in practice? So this is what we see as far as uptake of antiretrovirals for pregnant and breastfeeding women, and this is again the most recent data collected by UNAIDS, WHO, and UNICEF and reported in the Global AIDS Monitoring Database. And what it shows you is access to highly active antiretrovirals for PMTCT has steadily increased and has now reached about 80% of coverage in terms of all pregnant women living with HIV. But there's another interesting aspect to this, which is that, in fact, whereas in the past, a relatively small proportion of those women were on lifelong ART, what we've seen in recent years is that that proportion has been increasing and increasing. So the tiny wedge that used to be women that were on option B or option A has now disappeared, essentially, and virtually all women who are accessing PMTCT ARVs are actually on lifelong treatment. So that sounds pretty impressive, and certainly sounds like we've accomplished a lot. But has this actually resulted in the changes that we want to see? The numbers of new infections have indeed declined. This is the latest data, again, from the database. But what it shows you is that we are currently estimating around 180,000 new infections per year. And that's pretty far from the goal that we wanted to get to of 20,000 new infections by the end of 2020. So this reassuring situation is perhaps not quite as reassuring as we thought. And I want to focus on what I think are 5 important reasons for why we shouldn't be celebrating the policy rollout of option B+. And I'm going to go through each of these in turn and briefly summarize some things that you already know, some things that you've heard, and then perhaps try to pull it together into some kind of understanding of how we move forwards with this. And I want to remind us, those of us who remember the 4 prongs of PMTCT, that they're still kind of relevant to our thinking. And actually, all of these 5 things track to one of those prongs. Primary prevention, prong 1. Improving access to family planning, prong 2. Initiating and maintaining women on treatment, prong 3. And then lifelong continual support for women who are on lifelong treatment, prong 4. So the prongs still remain relevant, and I'd like to start with the first of these issues, which is related to the slow decline in new infections among adolescents. Of course, declines have been much more impressive in the younger child population. As I just showed you, in 0 to 14, we've seen this very nice annual decline in the number of new infections in kids. For adolescents, that slope is much, much, much more gradual. So although the numbers are going down, the estimates suggest that that decline is extremely slow. And again, this is very far from the target that we want to achieve of 100,000 new infections among adolescent girls and young women by 2020. So if you then sort of look at some of the other issues that I think are important to address, we learned this morning from John Kinuthia about the uptake of PrEP in a program in Kenya. And he also showed this data from Alison Drake and her colleagues that I think we're all familiar with, which was a meta-analysis that first highlighted some of the high risk that we see of mother-to-child transmission following incident infection in pregnant and breastfeeding women. And what her analysis showed was that there is an odds ratio of 9 up to 15 times higher for women who are diagnosed with incident infection when they're treated with antiretroviral therapy. But as John also showed us, not only are mothers that acquire incident infection at high risk of transmitting, it turns out that pregnant women and postpartum women are at high risk of acquiring HIV in turn. And this was data that was presented at CROI this year, which again highlighted the fact that pregnant women have a threefold higher risk of acquiring infection per sex act. And when you go into the postpartum period, that number increases to just over fourfold higher risk. Now, Tuhar Din and her colleagues took this analysis one step further, and they studied nearly 10,000 mother-infant pairs in South Africa by looking at dried blood spots on the babies at around 4 to 8 weeks of life. And what they did was they measured the presence of HIV antibody and, of course, of HIV DNA in those dried blood spots in order to try to understand what the source of infection was in the mother. Was it a prior positive that was known, or was it an incident infection? And to try to correlate that with the risk of transmission to the baby. So they compared that data with historical records from the mother, and what they showed very nicely was that although incident infection, as they had defined it in their protocol, accounted for only about 6.7% of the mothers that were seen with HIV, they contributed 26% of the infections that were identified. Now, it's very important to remember that this is very specific for the South African context. But I think what it tells you is that in a high-burden, high-incidence country like South Africa, you cannot afford to ignore the role of incident infection if you really want to try to achieve elimination of transmission. The third issue, it's the old tough nut of lack of access to family planning. And this is again data from 2013 to 2017, which shows the percentage of women under 35 using any type of contraceptive method by age. And what it shows you is that the youngest women, adolescent girls 15 to 19, as well as women in the 20 to 24 age group, these are the women that are at highest risk of acquiring HIV and most likely to become pregnant, have the worst access to family planning. And lest you think, well, maybe women are choosing not to have family planning because they want to have babies, a recent, very thorough analysis that was published in Lancet Global Health in April of this year highlighted that around 44% of pregnancies across the world, and especially in sub-Saharan Africa, are actually unplanned pregnancies. So I think this lack of access to family planning represents a real and significant unmet need. We don't know how bad this is, segregated out for HIV-positive women, of course, but there's no reason to assume that it would be any better, and it's quite likely that it's even worse. The fourth point that I wanted to make is that underneath that map that shows, high uptake of B+ and high levels of coverage of ART, there is also a large variation in terms of regional differences. So although in Eastern and Southern Africa, where the bulk of the disease is, you have 93% coverage, out in Western Central Africa, that coverage is actually 47% and appears to be very slightly lower than it was last year. That's a real problem because Western Central Africa accounts for around 20 to 25% of all of the pregnant positive women living with HIV. And finally, I want to touch on the issue of poor retention. Now, we know that data on retention is very bad, so I wanted to illustrate this with a little kind of analysis of the process that was undertaken to review the spectrum model this past year. And they undertook a review, which is unpublished, but it was conducted by colleagues from Harvard University. And they found 23 studies, all of which most of which were from sub-Saharan Africa, which contributed 44 individual retention estimates. Some of these studies were multi-country, some looked at multiple interventions, some were tracking cohorts over time so that they could report on retention at different time points during pregnancy and in the postpartum period relative to when the woman started antiretroviral therapy. And the study also included women who were first diagnosed in ANC and women who came in already positive into ANC. And in the final analysis, what Spectrum has now put into their model is that 25 and 20% respectively of women already on ART and women newly started on ART will be lost to follow-up during the antenatal period before they deliver. For the postpartum loss to follow-up, the data was drawn largely from Malawi and assumes a 2% per month rate of loss to follow-up for women after they deliver. So what that means when you look at the spectrum modeling is that there is a higher rate of transmission now, both due to peri and postpartum infection in spectrum. These numbers are a little higher than what we had seen previously. And what's also changed is the relative ratio of peripartum to postpartum transmission. It's much more even. Indeed, more infections seem to be peripartum than they were than postpartum in the latest version of the spectrum modeling. And I think that's driven in large part by the new retention assumptions. So in my last couple of slides, I want to address what we can do to try to fix some of these issues. And we go back to Homer Simpson rather, who I think is obsessed with donuts and can't think of anything else. And I think we've been a little bit obsessed with scaling up B+. So what I'd like to propose is that we have a bunch of solutions that we know about. Many of these are really well tried and tested. Community engagement, mothers to mothers, involving men in the delivery of services, combination prevention, new tools like the dual syphilis test. These are incredibly important. They're evidence-based, they're proven interventions that work to address many of those problems that I identified. But the question is, how do you choose between these interventions? And what I'd like to propose in my last slide is really a new way of thinking about how we program around PMTCT. Differentiated responses is everyone's favorite thing. I'd like to bring that into the PMTCT discussion. And this is completely blue sky thinking, so, shoot me later. And it's intended as an illustrative example. But what I'd like to propose is that we classify countries using some kind of typological approach, either high coverage with either high or low burden, low coverage or low burden settings. And then we define menus of responses that make sense for countries in those contexts. And I've just thrown out a few ideas here. There could be a maintain approach, a scale-up approach, and an integrate approach, depending on the type of context you have. And the sorts of things we might be looking at are coverage and strengthening retention if you've already got good coverage, and focusing on incident infection if you're in a high prevalence setting. If your coverage is low, then maybe you need to look and understand why that is. In West and Central Africa, it could be weak antenatal systems of care. It could be user fees that are really blocking that increase in coverage that we're seeing in West and Central Africa. And then when you identify those, we should be targeting scale-up. So it's business as usual, scale up, scale up, scale up, but in unusual places and in unusual ways. And then I think if you're in a low prevalence setting, the focus could perhaps be on integration, on using services and technologies like the dual test for HIV and syphilis to try to achieve high levels of testing in those settings and ensure that those few women that you identify are linked reliably to care. So, food for thought. We've made significant progress, but we're far from reaching our targets and commitments, and what got us here will definitely not get us there. So it is important to scale up. I don't want to say that those old things we've been doing are not important. They've been essential. But we may need to look at bigger picture issues if we're going to break barriers to access, and I think we need to take a differentiated approach to PMTCT. The end for PMTCT may not be near, but this talk, thankfully, is. And I'd like to thank all of these wonderful people who helped me prepare, brainstorm, and think. You can blame them for anything that you disagree with. Thank you.